Hello and welcome back to A Modern Pharmacist. Now, this week I'm going to go through about 3 case studies I think I've got lined up. And before I go into that, there's a few things that I wanted to cover or at least ask the question because over the past few episodes, I've heavily criticized healthcare professionals and also the system at the same time. And the reason I do so is because I'm the first person to critique and criticize myself in everything I do, whether that be business, performance in the gym, everything. I always go really hypercritical on myself. So it's not like one rule for one and one for another. But I was just trying to think, because these case studies, in each one, I obviously wanted you to, as the listener, to think about what would you do or what you think's right morally, and what would you do in that situation as a clinician? Because a lot of these things, I don't know where the blame lies, to be honest. Because as a healthcare professional, or as any professional, or any morally right person, you always try and improve yourself in every way that you can. So you should always be trying to take the onus on yourself and try and improve whatever it is that you can do. However, there are certain places and situations where there's only so much you can do, even if you know how to do one particular thing, that you are then restricted in how you carry it out. So, for example, in healthcare, if you I don't know, let's say you're very well read on a certain topic and you say, well, actually, this is the way that we should go about it, and then it's not funded by the NHS or it's not funded by certain guidelines, then you can't, your hands are tied to some extent. But so in me saying that, I do feel as though the blame does lie in maybe 60% with the system and 40% with the health professional in this case. And I want you to take that into these 3 case studies, and they are all anonymized apart from one, which is my dad, which he has also allowed me to do it. I have asked for consent. But yeah, they're all different things. So the first case study, I've got no notes anyway. I'm just doing this off the top of my head. Should have prepared a bit more for it. First case study is a young lady in her 30s, chronic back pain, and went for an MRI. I've done this on social media recently, but they went for an MRI and the results come back as it was what we would expect within the normal population of someone of that age. Nothing really that we would advise on. We should really be cutting you towards medication, which wasn't really a good answer for us because we don't want to put this patient on pain medication because they can become very addictive. They've got a lot of side effects. Not a very nice thing to be on from your 30s and being reliant on it. So we then obviously pursued another appointment for this person, and when they went to have a consultation with the GP, they went through a few things and said, well, let's get some blood work for potential autoimmune disease, which was what I would have liked to have done. So we got a few things like HLA-B27, we went through ESR, anti-CCP, so all the rheumatological conditions. And when we were there, this person has also tested for their CRP. So for anyone who doesn't know, CRP stands for C-reactive protein. And if you test for it, it just shows that your body is reacting to something. It's not specific. It doesn't tell you whether it's a certain infection or whether it's stress or what inflammation it is. It just means that there is something going on in your body that your body is trying to protect itself from. That's essentially what it is. And if we check for it in the NHS, we have a cutoff value of 5. So anything below 5, we wouldn't really look at. We would say, do you know what? There's nothing there acutely, so let's leave it. But there is a test called high sensitivity CRP, which allows you to look at values below 5, and it gives you a reading all the way down to 0. And the significance of this is that there's a lot of data at the moment that is showing if your CRP is raised even above 1, but more likely above 3, over a long term, that can lead to a lot of ongoing conditions, which can lead to other inflammatory conditions. And if you look back at the pathophysiology of most conditions, there is some sort of inflammatory element to it. Broadly speaking, I don't want someone to come at me and give me an example where it's not, but broadly speaking, it is. So in my opinion, I would advise anyone to sort of know what is their baseline level of CRP throughout the year. And if it is chronically low grade elevated, then I would like to know, why is that? Is there something that's affecting the part of the diet? Is it due to excessive stress? All these things. Now, the person in question, the patient, had a level of, I believe it was 1.1, and this was a year ago. They've then since repeated it about 3 months ago, and it went up to 2.3. So to me, that is basically doubled. So it shows that something is happening. And when this information was presented to the GP, they come up with the blanket. It's less than 5. We wouldn't look at it. But from my point of view, as preventive health is something I'm passionate about, that would tell me something's going wrong. And wouldn't it be good to get to the bottom of it now instead of 5, 10 years time? This person turns up when the inflammatory condition that they potentially have has come to full fruition, and now we are reactively treating this patient. So that was the first case study. I would just like to know what other people would think when it comes to that, because again, the actual investigations and the consultation, looking into it maybe a couple of times, wouldn't really be that much of a burden on the NHS. Bear in mind, this patient is a high paying taxpayer, so they had more than paid into the system, which is more than can be said than probably 90% of the NHS users. I think it would be more beneficial to do that now. And instead of maybe in 10 years' time, it could be that we are using a very, very expensive drug. It could be a biologic, a MAB, where it's in the thousands of pounds a year to treat this patient, when it could have been probably offset earlier on. And the reason why I think it was also deterred, apart from the fact that it is in guidelines and they don't really support preventative health, I also feel that a lot of physicians don't feel comfortable in these, I wouldn't even say new guidelines, they've been around for a while, or new information. I just feel like a lot of clinicians are not comfortable outside acute health issues. So that's why I also think the blame falls on the health professional for not looking into their continuing professional development on a higher degree, because this could really lead to a beneficial outcome. So that's the first one. What would you do differently? In my opinion, it would be, let's investigate what is happening, because there's clearly something that's going wrong. The second case study is my dad. So I'm not going to go into his full past medical history, but he had 2 heart attacks at 50 and 51. And since being treated for a heart attack, this is what this case study is about. He's had blood monitoring probably on average every 3 to 4 months, which is a good thing. So I advocate for that. Some blood markers could be more advanced, but bear in mind, he's still getting blood monitoring and being looked after on a daily basis, every 3 months. But one of his blood tests come back and it was a HbA1c, which I've explained in other podcasts. This is the average blood sugar reading over the previous 3 months. So it gives us a good idea of his metabolic health, his insulin sensitivity to some extent, and whether he has diabetes. And for those who don't know, a value of less than 42 is classed as normal. 43 to 47 is classed as impaired, so pre-diabetic. And 48 and above is what we would class as diabetes. Now, the thing with HbA1c is, in a man of my dad's age, is that if his HbA1c goes above 48, there's a great chance that he would be classed as type 2 diabetic, because type 1 diabetes is usually diagnosed in young patients because it's autoimmune, and it would have come to full fruition by his 50s. Yes, there are some examples of people in the 40s where they can get late onset type 1 diabetes, but in the majority, it would be classed as type 2 diabetes. And in the pathophysiology, so that means essentially what's going wrong with type 2 diabetes. If you look 10 years before, on average, the body is not regulating blood sugar to its greatest ability. So it's secreting a lot more insulin to just keep everything under control. And this slowly starts to show in your HbA1c, and it will creep up into that impaired range, which is 43 to 47. So my dad's 3 years ago was 43, so classed as pre-diabetic. The result annotation by the GP was normal. Well, actually it didn't. It said satisfactory. So I said, that's clearly not satisfactory, because he's never had diabetes. He doesn't have any family history of that. So that's not satisfactory. Let's see what happens again. Repeated it again another 3 months later. His HbA1c was still 43. Same result, satisfactory. I mean, that didn't actually make me aware of this until earlier on this week, which is why I wanted to do a case study on it, because for the past 3.5 years, my dad has had an impaired glucose tolerance. So he has been at a HbA1c of 43. And I said to him, if we let this go on for on average 7 to 10 years, he would develop type 2 diabetes. And we've had all the data all along. So my first issue is that we're not getting enough people tested. But in this case, he's getting tested every 3 months and we're still not acting upon it. And diabetes is a it's a massive financial burden on the NHS. I actually don't have the figures to hand, but I think it's over 8 billion a year is spent on diabetes. So the fact that a simple intervention, in this case, HbA1c of 43, would be a simple conversation with my dad and say, okay, well, what medication is he taking? He's actually taking a statin because obviously he's had a heart attack, which can cause impaired glucose tolerance. So that could be a potential cause. But the biggest factor is more the fact that he's got a lot of fat mass. And when I mean a lot of fat mass, if he listens to this, it's not. My dad weighs, I think he's high 90s in the kilos. He's 5'10", 5'11". He's got a normal build. He's a construction builder, landscaper, so he's got the normal frame. But he could improve his muscle mass. He could also improve his cardio metabolic activity. So he could improve his zone 2. And these are targeted things that would significantly improve his HbA1c. But because the health professional, in my opinion, doesn't have that much experience or confidence with it, they've merely cut satisfactory, which is incorrect in the first place. And scary on the other hand, because if he didn't tell me that, he was literally on his way to a one-way ticket to type 2 diabetes, which is absolutely insane because it's a very preventable condition. Probably one of the most preventable conditions out there. And it's been proven multiple times. And if anyone ever tells someone that type 2 diabetes is irreversible, there is a lot of data. And I'm aware that some of the audience may not be heavily into the studies or the science, but there was a study done back in early 2000s, and I always forget the two authors. One of them was, I think, Professor Rob Taylor. So he was from Scotland, and he got type 2 diabetic patients and put them on a massive calorie deficit. And it was in the realm of 750 to 850 calories a day. And after 12 weeks, near enough reversed their diabetes from reasonably high numbers to normalish. Well, I think a couple of them come back as pre-diabetic and some of them went to normal. And that was just 12 weeks. And that was just explaining the theory that excess fat leads to the pancreas and liver being clogged up, which then impairs the insulin that comes out, which then obviously leads to type 2 diabetes. Well, the point here is that because it's maybe not in guidelines to intervene with this pre-diabetic patients, I think it is. I actually need to really look up on this because it's hit and miss with the consultations that I see. The ones that I do see that intervene, again, not the best, and the people who are giving them are not well qualified to do this. And out of all places, I went to a family birthday party last night, and I got off quite early. I don't really drink. I don't drink, actually. I've not drank for 3.5 years. But the conversations I was having in the very early part of the night was with a couple of physiotherapists, and they were saying the same thing, is that why would you listen to people who don't look like they know anything about physical health, which is largely the case. A lot of these people given the consultations usually overweight, obese. So why would you listen to them when they've only done a couple of hours in university and clearly don't exercise the advice themselves? But in my dad's case here, if it weren't for me intervening, so now I'm going to obviously give them a more structured plan, which is hard for them. Anyone who does manual labor will find it more difficult because they are more active of a day than me, but their activity is not targeted. So where my dad's activity is 12 hours basal up, walking around, it's obviously doing them very well. However, when I go to the gym, the 40 minutes that I'm doing strength training, it's targeted at growing muscle, or the 40 minutes I do cardio is targeted at a certain cardiovascular range, and I will get more efficient and greater results because I'm going in with a purpose, essentially. So that's what I will be doing with my dad. But I just find it quite scary that there are people out there who have no access to medically trained people in the family and wonder why 10, 15 years later they're developing these conditions that when I do have the consultations with these people, say that this could have been prevented 10, 15 years prior. So that's the second one. What would you have expected to have done? And how would you react if you were a patient who has this and it's coming back as satisfactory? And they have been in the comments on at least 8 of his blood results. I think he's had 8 since his heart attack with this HbA1c, which is it bordering clinical negligence, or is it just the system that we've created because we're not promoting all these really healthy habits is just so stretched? I really don't know. I don't think there's a plausible explanation as to why this is being missed. So that's the second case study. And what I would have done was intervene from the first one and say, make these changes, tell me what it is that you do, make a lifestyle diary. And I would like it to be as thorough as you can possibly make it. So from everything you eat, how much you sleep, how much you exercise, what you do, and how much stress there is subjectively. And then in 3 to 6 months' time, we then put in a plan and say, okay, well, these things have not changed. We need to optimize this. And then we would get his HbA1c with that. I am fully confident in that. So I'm going to do that with him, and I'll report on it probably in 6 months' time when he gets it repeated. Now, the last case study is to do with testosterone replacement therapy. And this one's probably very relevant because there's a lot more men that I'm speaking to, especially in the late 20s, low 30s, who are going for this types of therapy, thinking that it's a quick fix, that they're not able to grow muscle, they're not having the same libido, all these other things, when in reality, there's a lot of simple fixes. A lot of it is due to having a high fat mass. So any of the testosterone's being converted to estrogen. A lot of these people drink a lot of beer, and they do contain estrogenic compounds in them. There's a lack of, I just think, life in general, if we take it away from an objective point of view, if you look at life in general now, we are being heavily suppressed within the Western cultures. You can't say certain phrases, you can't say certain words, you can't do certain things unless you fall into these categories. And it's really suppressing a lot of people, which is then obviously affecting them mentally, which can also have a big, massive effect on your hormones. So there's so many things that are not conducive to optimal hormonal health. And that also goes for women, probably more so for women than men, if I'm being honest, because why do women need to work full time when they've got a baby on the way, which makes absolutely no sense. No other animal really does that. They obviously cater for the young. Another conversation. But anyway, this patient had been seeking exogenous testosterone, meaning that they were injecting it into a muscle, and they had been since the age of 18. Now, this patient was doing it on the grey market, the black market, whatever you want to call it. And they come in for a blood test 2 to 3 years ago with the NHS. And this was the first time they had a blood test since being on replacement therapy, because obviously they weren't being monitored, they weren't being prescribed, and they never presented to the GP. The only reason they got it done was because they were a new patient at the surgery. Now, testosterone, and obviously improves your muscle function, improves muscle size, libido. There's so many benefits of having testosterone. That is why a lot of men seek it as the quick fix. But one thing it does at the same time is it stimulates red blood cell production, so hematopoiesis. Now, I've actually got a bottle of water here. So if I was to take this as a vial of blood, in the average person, I would expect 45% of it, give or take, to be red blood cells and other cells that are circulating within that blood. And anything more than that, it obviously will increase the viscosity, the thickness of the blood, which is something we don't want to do, because if the blood's too thick, it has the greater chance to clot. It also puts more strain on the heart because it's got to pump through this. Essentially, it's going from more of a water-based blood to more of like a treacle. So it's going thicker, so you've got to pump harder, which then increases the muscle size of the heart. It can lead to dysfunction. So these are the things that you need to be wary of if you are taking testosterone. So you should always have a full blood count, which measures something called your hematocrit, which is basically how much of that blood is cells. So when this patient come in and got a blood test, his hemoglobin, which is the iron carrying component of blood, should usually, in a man, I mean, I would say anything, it's meant to be greater than 120, 130, but when it starts creeping up towards the 180s, you would start to be concerned. Where's that coming from? This man's was 185. And the result, the comment was, again, it was satisfactory, if believe it or not. And at the time, his hematocrit was 57%. Again, over the range where we would like it to be. No intervention whatsoever. Fast forward 3 years later, he's still taking the testosterone through an injection because he has really bad body dysmorphia, which is, I've had body dysmorphia, or do have it. I feel like anyone who goes to the gym who reasonably trains to a good level and wants to look after their physique has body dysmorphia. You look at yourself, you look at your arms and think that looks quite small. But there's obviously a lot of people who are affected to a greater extent. And when this patient presented 3 years later, he now has severe heart failure due to enlargement of the heart. And that's all due to the fact that he's been on a high dose of exogenous steroids without any monitoring. His hematocrit, when it come back now, is in the 60%, which is absolutely insane. So his blood is on average 40% thicker than the average man, which when the heart's doing that every single day, how many times it beats? The average heartbeat is what, 60 beats a minute? Over 20, 30 years, that is going to have its toll or take its toll on the body, which it has done. And now his heart can only pump out at an efficiency of 10%, which is one of the worst heart failures I've actually ever seen. And this man is only 41. And he is now on a plethora of medication. He's on, I think it's like 8 medications that he's on just to manage fluid overload. And his exercise tolerance, which is how much he can basically do before he becomes dysfunctional or out of breath to a severe point, was 10 yards, which obviously he must have been a really good trainer because he was on a high dose of steroids. And he's gone from that to not being able to walk 10 yards without gasping for air. Now, whose fault is this? Yes, it is the user. He should have had full autonomy on what he's doing, and you should be looking into that before putting something into your body. And I advise that of anyone, even if it is an approved prescription drug, you should always be looking at, how is this going to affect me? Does it have a recognized mechanism of action? Does it have long-term studies in whatever it is that you're looking at, whether that be fertility, whether that be heart health? You should always be looking at this before you put it into your body, let alone getting it from the grey or black market and it being an injection, because then you remove the protective capacity of the liver. So yes, 100% it is on the patient in this case. But when he did first present 2 to 3 years ago, we should have, not me personally, because I wasn't the physician, but the system should have looked into, why is this patient so high on these blood markers? Does he have a hematological condition, which can happen? Some people can naturally overproduce this. Or is he taking something which is most likely to be steroids because of his physique, and he's getting it, and we need to be able to dose reduce, and we need to keep him under active surveillance. So that's where the system doesn't accommodate for these people. And again, I can't go back in time, but from previous experience, if these people would have sought a blood test under the age of 40, it probably would have been rejected. And as I made a previous comment, was someone could go and drink themselves into oblivion, or smoke themselves, or smoke like a chimney, whatever you want to call it, or whatever analogy you want to use, and they would get the right amount of attention that they need to treat a condition that was probably 99% inflicted by themselves. So if this person is proactive in their health, trying to make it better from what they perceive to be, because improving muscle mass is known to improve your health span, longevity, metabolic health. Obviously, the way he's doing it is not healthy. Could have done with a bit more education around that. The system could have intervened, but he's more proactive in his health than someone who's smoking 20 cigarettes a day and drinking 5 pints of an evening. So I don't see the differentiation between the two patients there, especially if he's a taxpayer, which he probably is, unlike a lot of the people who abuse themselves in other ways through other drugs. I just find that a very difficult situation, because it could have been heavily prevented. Obviously, this is the thing with prevention, is that people don't think it's going to happen to them. And little did he think that at 41, he would have the heart capacity of someone who is near enough on death's door, probably got a few weeks to live on average. He probably never thought that, especially going from a really good physique and low body fat percentage. But this is why I advocate for any intervention or investigation as early on as you can, because there are signs. The body does tell signs and show signs a lot earlier in the majority of cases. And there's things where it's common sense anyway. Taking steroids, doing other drugs, they're not obviously beneficial for your health. So look into what is actually happening. So in this case, I would have intervened, looked into why his blood markers were so raised, asked a bit of personal history. You're not on any prescribed medication. Are you using anything outside of the pharmacy and NHS? And he might have said, you know what, I'm on injectable steroids because I've got body dysmorphia. Okay, well, let's treat the body dysmorphia, which will then reduce your compliance or reliance, sorry, on the injectable steroids, and then you will have a better outcome. Might have still have heart failure, but he might have been in a 25-30% ejection fraction for his heart as opposed to 10%. So they're the 3 case studies, all different, but all have an underlying thing where, is it one, a lack of education for health professionals? I think so. I think it's a lack of education and a lack of confidence. But where does that onus then lie on? Is it on the professional? I fully believe so. Like I said, I go out and look at all these studies. I look at certain things for exercise. I'm going today to do more exercise later on after this podcast. So I feel like if you want to be the best in anything that you do, you've got to push the boundaries. So yes, responsibility lies there. But the guidelines, the system needs to be able to provide for assistance for these people who are trying to push the boundaries for health, as opposed to putting in legalities where it is completely restricting what you believe in. And yeah, there's so many things I could discuss. I just feel like the model of healthcare is broken. But as you could see from all these 3 things, there was a lack of knowledge, there was a lack of infrastructure in place to support these people. And even in my dad's case, it's not even a lack of knowledge. It's clear as day that he will have type 2 diabetes if he carries on in 7 to 10 years' time. Why are we waiting? Why do we leave it and go, do you know what? We can treat type 2 diabetes really well, which we can, but we shouldn't be getting it in the first place. We should not be having patients who are draining from the system. And is that on my dad's fault? Or is that my dad's fault for his lifestyle? Yes, again, everyone is responsible for their own lifestyle. And he clearly knows that having more muscle mass and less fat is more beneficial for his long-term health. Clearly knows that. But when he's getting the advice, and I've listened to some of the consultations, I listened to one that he had about 3 weeks ago about these bloods actually. And the advice it was poor. What are you going to do? I mean, I couldn't even decipher what to do with it. And I work in healthcare, and me and my wife, we both work to a high degree in healthcare. We are well versed in how to treat patients, but we are trying to push the needle with this preventative health, because it is the easiest thing to do on the planet is stop it from happening. And then there's less mess to clean up. And it's not like we don't have the data. Yeah, 3 different case studies anyway, before I go off on another rabbit hole ramble. But 3 different ways in which we can manage them, but all have the same general answer, which is we need to act early. But sadly, we are still further away from that than what I actually once believed. Right. But yeah, that is today's episode. Hopefully you did take something from it. Hopefully if someone, well, not hopefully no one in your family is experiencing any of these case studies, but if you do know someone, then maybe look into it a bit more, because I always say to people, no matter what profession it is, whether it be a builder, whether it be a pharmacist, a doctor, always question the person, because everyone is human and we are liable to mistakes. So always ask. And you don't have to do that disrespectfully. You can just say, is this the right plan? Is this what you would expect? I thought this was this. It's always good to question it. I always welcome it to patients to me, because, and obviously again, if someone's asking a question that I've not explained properly, then it further enhances my professional qualifications and my communication towards them. But anything that I have discussed in this podcast is for informational purposes only. It's not meant for advice. If you can get seen by your physician, by all means do so. But as you are probably grasping by these podcasts, it's who should you be seen by and who should you trust with your health. And I can see more than ever why people are against systems or have a lack of trust within these formats. But thanks for watching or listening, and I will see you in the next one.